What I will do today is give you some overview of the new developments in immunotherapy, and I will use my experiences in urothelial cancer and prostate cancer to highlight some of the new ideas. These are my disclosures. To start off with the immunotherapy of urothelial cancer. Urothelial cancer is one of the most frequent diagnoses in oncology. It's the 5th most common cancer, especially the non-invasive bladder cancer. That's happening quite often. It is associated, the development of urothelial cancer is associated with the use of toxins or chronic infections. So, and the good thing about it is if there is a lot of toxins involved, there are usually also a lot of mutational burdens. So there is usually, these tumors are indeed very immunogenic. And we know already for a very long time that urothelial cancer is an immunological cancer, because it was already for a very long time ago that we are using BCG to really start treating the superficial urothelial cancer. And the idea is that you stimulate the immune system, and in this way you are also activating the immune system against the cancer. In 1990, it was approved, BCG, and that's now standard therapy. So it started already a long time before we were using the immune checkpoint inhibitors. Talking about the immune checkpoint inhibitors, just to give you some idea is what we are talking about. We're using now these days either the anti-CTLA-4 antibodies to inhibit the immunosuppression caused by the expression of CTLA-4, the anti-PD-1, and the anti-PD-L1 monoclonal antibodies. But what's very important to realize is that this is not the only story. The most important part is that you need some different molecules, different cells, really to have that the immunotherapy should have some effect. This is the typical one where indeed there are the T cells present in the metastases. There is the expression of PD-L1, so the immunosuppressive molecules. And in this way, if you're now treating these patients with PD-1, for instance, then you can really expect that there will be a response, because there are present, first of all, it's present the PD-L1 expression. Secondly, there are the T cells, and you really need the T cells, because if there are no T cells, the tumor cells won't be killed. So this is in approximately 20% of all the patients. That's why the response rate of all the clinical trials with immune checkpoint inhibitors, usually you have a response rate of approximately 20 to 30%. And why is it? Because only in 20 to 30% of the cases there is T cell infiltration. Then we have the other approach, where here in this case there are the tumor cells. There are some other cells, but there is no expression of PD-L1 and there isn't any T cell infiltrate. So if you now would give the infusion of your checkpoint inhibitors, there won't be any response. Then in this case over here, there is the case is that the PD-L1 expression is there, but there are no T cells. So in this case, the infusion of the immune checkpoint inhibitors will not lead to destruction of the tumor cells. And then this is another important variable, is where you have everything is present. The T cells are there is PD-L1 expression, but there are immune suppressive cells like the myeloid-derived suppressor cells. And this is really inhibiting an effective T cell function. So there are different ways that we can look in and try to predict what's really happening in immunotherapy. Starting off, what do we know these days? We had some interesting clinical trials in urothelial cancer. The first one I will discuss is the phase 3 study in atezolizumab versus chemotherapy in second-line treatment. A phase 3 study, very encouraging phase 2 data. And then they designed this clinical trial where they compared the immune checkpoint inhibitor, the anti-PD-L1, versus the chemotherapy. And then we're looking, this is the important part over here, is based on the expression of PD-L1 on both the tumor cells and the infiltrating immune cells. They were expecting to, based on the phase 2 data, that they would really see a higher proportion of responses if you have a high expression of PD-L1 on either the tumor cells or on the immune cells, and that this would predict the good responses in this phase 3 study. Unfortunately, it turned out when they were looking at the high expressors of PD-L1, is that the study was really negative. So there was no difference in overall survival between chemotherapy and atezolizumab. So that was a big disappointment for everybody, and nobody was really expecting this kind of results. But what they did very elegantly is they really tried to dissect why it didn't work. And then what they discovered is that there is a difference whether there is a high mutational burden, that was here illustrated over here, or whether there's a low mutational burden. And if you look at the bottom of the slides here, it's approximately 50-50%, so low versus high tumor mutational burden. And it's particularly the patients who have a high mutational burden who have a very favorable response on the immunotherapy. If they were looking at the PD-L1 status, in the middle there are the results of just based on the PD-L1 expression, no significant difference. But if you now combine the high tumor mutational burden and the PD-L1 expression, then there is a marked differences. So there is now room for improvement in this particular population of patients, which is, if you look at the number of patients here on the bottom, it's only a small proportion of the patients with urothelial cancer. So the message from this clinical trial is that we need to do more than just giving these kinds of treatment to all patients. We have to look at tumor mutational burden, and we have to pay attention to the PD-L1 status. These are the conclusions. So overall, negative study, but there are some indications how we should work towards that it's really working in those patients with a high mutational burden, so a lot of neoantigens, and that we should really look at the PD-L1 expression and try to combine it. Then the second clinical trial, that's the phase 3 study with pembrolizumab, anti-PD-1 versus chemotherapy. Very similar design of the study, 1-to-1 randomization. And here, if you look at the response rate, it's higher in the group treated with the immunotherapy compared to the chemotherapy arm. Here, the overall results of this clinical trial. This is a positive trial, second line, so after the cisplatin treatment. And there, it's a really positive trial now with a hazard ratio of 0.7, an impressive p-value, and approximately 25% of the patients are surviving after 2 years. So this is now, at least in most of the countries in the Netherlands, this is the registered drug for urothelial cancer. If we now are looking in this case for whether there is any immunoscore, what you can use to really select patients for the clinical trial, it turned out that there was no difference between all patients and the patients who are really expressing a high PD-L1 expression. Unfortunately, every company has its own trick to score. One is only, and you really have to pay attention to it. For instance, BMS is really only looking at the expression on tumor cells. Roche is looking at both the tumor cells and the immune cells. Here, Merck Sharp and Dome is looking at both the tumor cells and the immune cells, and then dividing it by the expression of the tumor cells. So everybody has his own antibody, his own method. So, and I will tell you why this is so important to really pay attention to the different assays what we are using. If we are looking at when can we expect to see a response, in most, I would say in 90% of all the patients, within 8 to 9 weeks, you can already observe a response. Approximately 10% of the patients have a delayed response, what is illustrated here on this slide. So it's good that at least within 2-3 months you can really decide whether this treatment is working, yes or no. And then the good thing is once there is a response, it's usually a very long-lasting response. If you look now here at the top of this graph, this is the overall survival of the patients who have a response on the immunotherapy, on the pembrolizumab, and approximately 80% of the patients have a durable response. And that's very important to consider, because if there is another complication of the treatments, which is the sarcoid-like reaction, where you get enlarged lymph nodes, and if it's happening in one of the patients who had a response early on, and it looks like that you have progressive disease after 1 year, you really should be very careful, because it could well be that this is not progressive disease, but this is a sarcoid-like reaction, and it's happening several times per year. That the patient is being diagnosed as having progressive disease. You take a biopsy, and it's just a granulomatous infiltration of cells. And I had one patient, for instance, a lot of enlargements of lymph node, but also lesions in the bone. And it all turned out to be sarcoidosis. So this is, and this patient was already started again on chemotherapy when we did all the analysis and took biopsies from all these different metastatic sites. So you really, this is very important to consider, that usually if there is a response, it's a durable response. Then what can we do in first line? In first line, chemotherapy is usually, cisplatin-containing chemotherapy is giving the best results. approximately 40 to 50% response rates, durable response rate. But if the kidney function is not good enough to really give the cisplatin, then the alternative is carboplatin. The problem with carboplatin is that if you look at the tail of the curves, is there are no really long-term survivors. That's different from the cisplatin-treated patients, where approximately 10 to 15% of the patients usually those are the patients with only lymph node metastases, is that these patients can even be cured if they only have lymph node metastases. With carboplatin, this is hardly seen in this population of patients. But if we are looking at the response rate, it's still approximately 40%. So it really makes a difference is whether you are, if you want to achieve a reduction in the size of the tumor cells, then you need the chemotherapy, and because the response rate with the immunotherapy is a lot lower. Here are the results of pembrolizumab, and we have similar results with the atezolizumab data. Quite good survival results for this group of patients, is usually very well tolerated. So this is really an option for the patients. But if you're now looking at the response rate on pembrolizumab or atezolizumab or one of the other drugs, it's approximately 20 to 30%. So it's really significantly lower than with the chemotherapy. So that's something you have to remember. Then there is another, to make it more confusing, here in this setting, the PD-L1 status is really predictive for the response. And this is shown here on this slide. Here is the low PD-L1 expression, and here is the high PD-L1 expression. So there's a marked difference. And based on these differences, the EMA has really restricted the use in first line of the immune checkpoint inhibitors based on these immunoscores. And then you really have to keep in mind that you really need the assay which is associated with this particular study. So not the cheapest antibody they should use in the pathology department, but the appropriate antibody should be used. So, and this is, at least in the Netherlands, is still an issue because most of the pathologists don't have a lot of experience in scoring the PD-L1 expressions on tumor cells or on the immune cells. And that's what's really needed. So we're working towards a centralized system where at least there will be around 6 pathology centers who will have experience in scoring, doing the immune score. So that's very important. So for every antibody registered in first line, you need to look at the PD-L1 expression. There's another message on this slide, and that's here on the bottom. If we are looking for, yeah, it's working. Here, the lymph node metastases. It's a very small group of patients, approximately 60. But it's very similar results of what we have seen with the chemotherapy. Those patients with only lymph node metastases are doing far better than the patients, for instance, who have bone metastases or visceral metastases. So you really should think about immunotherapy if the patients have only lymph node positive metastases. What did we learn? And I make a switch what we also learned, because it looks like that pembrolizumab, nivolumab, avelumab, etc., are all the same kind of drugs. And I'll show you now some examples where there is indeed a difference between the different antibodies. Just basically, the Fc region of an antibody is very important because the Fc gamma binding domain is responsible for the antibody-dependent cytotoxicity. And there is this C1q binding site, which is responsible for the complement binding. And it turned out, and these are murine studies, and I would like to draw your attention to the last author on this paper, because two others received the Nobel Prize for Medicine this year for the immune checkpoint inhibitors, but Alan Corman was the first one making the monoclonal antibodies. And he really looked whether there is a difference between the different subtypes of antibodies. And here you can see if you just use an IgG1, and this is murine data, then none of the mice is tumor-free. If you use the IgG2b, there is a delay in tumor growth, but you can cure the mice if you use an IgG2a. And this has all to do with the antibody-dependent cytotoxicity. And if we now are looking at the different antibodies which are available, then we can see that indeed nivolumab and pembrolizumab are very similar, both IgG4. But if we now are looking at the IgG1, there are, for instance, avelumab is really an antibody which is causing a lot of ADCC, and this is really translated also in different toxicity. Because what we are observing daily in the clinic, that especially with the IgG1 monoclonal antibodies like avelumab, there is a lot more infusion reactions. Approximately 20% of the patients have an infusion reaction if you administer avelumab, while it's a lot lower, approximately 3% for the other antibodies. So you can expect to see a totally different range of side effects depending on the IgG subtype. Then the last part, what can we do with biomarkers? That's becoming more and more popular. This is just to illustrate that urothelial cancer is a very heterogeneous disease. If you do next generation sequencing, you find a lot of different mutations. But if you are now just to summarize what we have learned from all this, there is indeed some help here in doing the next generation sequencing. The good thing about urothelial cancer is that you can obtain tumor biopsy quite easily just by endoscopy. And here are some examples that we can predict whether the patients will respond to chemotherapy, whether they are likely to respond to immunotherapy or Herceptin or the mTOR inhibitors. And at least this will help us to give a clue what kind of drug is really the best treatment for urothelial cancer. And this is a very good publication last year in Cell, where they really looked at what you can do with all the different biomarkers and how this will really differentiate how we should be treating the patients with urothelial cancer. Not just one treatment for all the patients, but we should really personalize the treatment. And I recommend reading this publication. There are a lot of different clinical trials. Most of the immune checkpoint inhibitors trials are now underway in urothelial cancer because of course it's a very big market. We are participating in almost every study, it's really very, very hot to treat the urothelial cancers now with immunotherapy. And in the last 5 minutes, I will switch to prostate cancer, because for a long time, prostate cancer was not really a tumor thought to be very immunogenic. But fortunately, now this year, during the ESCO and the ESMO, we discovered that the pharmaceutical companies have reinvented that prostate cancer could be a good target for immunotherapy. This is just an example of how many different clinical trials are being planned or are underway. So almost every antibody is now being applied in prostate cancer. And what we have learned, at least in our institute, and that's work what I did together with my colleague Niven Mira, is we sequenced the biopsies of metastatic sites of around 200 patients. And there is approximately, and this part is the most important part, it's approximately 20% of the patients have a genetic profile, what is really predictive that there will be a lot of neoantigens and that we could be treating these patients with immunotherapy. And to give you an example of what we learned this year is really that approximately 4 to 7% of the patients have microsatellite instability. And these patients, these are the results from Memorial Sloan Kettering, that they have been treating 10 patients, and 50% of these patients had a very good response on the immune checkpoint inhibitors. These are our own results. In the red lines are the responses seen in the patients with microsatellite instability. None of the patients with microsatellite stability responded to immunotherapy. And what you can really see on the bottom of the slide, that some of the patients have a really long-lasting response. And this is illustrated here. This is a patient who received all kinds of treatments in the last six years. He had massive numbers of metastases. All these white spots are bone metastases. So almost every vertebrae is affected by the metastases. We discovered that he had microsatellite instability. We were treating him with nivolumab, and then all of a sudden the PSMA scan, which is quite specific for the metastases of prostate cancer, they all became negative. The only site which was still positive was the adrenal gland. We removed the adrenal gland, and later on he had one single metastasis in his jaw. We irradiated it, and at least now over a year he's disease-free, and we'll have to wait and see what's happening. But I show you this picture to really illustrate that apparently immunotherapy is really possible to really induce a dramatic response in end-stage patients. And so that's quite remarkable. And so we're now starting treating more and more patients with microsatellite instability in prostate cancer. In conclusions, if we're talking about urothelial cancer, the immune checkpoint inhibitors are applied in first and second line. In first line, we really have to measure the PD-L1 expression because it's only, the use is restricted to those who have an expression of PD-L1. There is a different mode of action between the different antibodies, and the next generation sequencing data are becoming more and more important. In prostate cancer, there are many new immunotherapy trials will be starting in 2019. Approximately 20 to 25% of the patients are eligible for immunotherapy, especially those patients who have a high expression have microsatellite instability. And what we are learning now, that there are some sanctuary sites for the immunotherapy. So we're learning every day. We are surprised what we can learn from one individual patient, and it's very nice, exciting times. Thank you.